Okay, without further ado, I'd like to present our moderator for this program, and her name is Dr. Shelby Leach. Dr. Leach is an assistant clinical professor at SUNY College of Optometry. She currently supervises 3rd and 4th years in the primary care pediatrics, infant vision care, and children with disability clinics. Dr. Leach serves as a co-instructor of record of the advanced topics in pediatric ocular disease elective. In addition, Dr. Leach participates as a masked examiner for PEDIG clinical research studies. She's a fellow of the American Academy of Optometry and current president of the SUNY College of Optometry Local Society. Dr. Leach, I'd like to hand this over to you.
Thank you so much, Betsy. Welcome, everyone. Thank you so much for joining us tonight. I first just want to start off by commenting on access during lectures. So we generally make the assumption that people who join in these lectures, whether optometrists, optometry students, whoever it may be, are, have typical hearing, typical vision, whatever it may be. And this is part of what we're going to talk about tonight. So I want to start off by saying, for those who may need it, I am a white presenting female. I have a white background behind me, and I'm wearing a white shirt, and I have brown hair. As Betsy mentioned, I am a current assistant clinical professor at SUNY, and I'll talk a little bit more about myself in a moment. All right, and financial disclosures, I don't have any. Our 4th year, Jenny Liu, who I'll introduce in a moment, does not have any either. And then Stephanie, they will be coming on a little bit later, and I will introduce her introduce them as well when they come on. But they work as an executive director for Project Let's, and we'll describe in a moment kind of what that is. So, as for an introduction, you already heard a little bit about me. I did do my residency at schooling and residency at Berkeley, UC Berkeley, in pediatrics, and then I came on to SUNY. Since I've come on at SUNY in 2018, I've started doing an online master's in public health through SUNY Albany, and I've become very interested in public policy, public advocacy, especially concerning children's vision and children with disabilities. So a little bit how I got into this realm, and then somebody who I greatly admire and been working with a lot on this stuff is the 4th year Jenny Liu. She's a 4th year student at SUNY Optometry. She's the founder of the college's chapter of Project Let's, and additionally is the advocacy chair of Spectrum, the college's LGBTQIA+ club, and is Justice Ambassador of National Optometric Student Association's Political Action Committee. Prior to optometry school, Jenny received her Bachelor of Arts at University of Pittsburgh with a major in philosophy, minors in studio arts and chemistry, and a certificate in global studies. Informed by their own lived experience with mental illness, neurodivergence, intergenerational immigrant trauma, and disability, Jenny is dedicated to intersectionality, transformative justice, community building, and healthcare as a human right. Jenny hopes to someday work at both the micro and macro levels of creating equitable, accessible, and inclusive eye care, and affecting systemic change for all marginalized populations.
Thank you so much for joining us, everyone. I just want to say real quick, a land acknowledgement. I'm joining you all here tonight from the unceded Indigenous land of the Munsee and Lenape peoples. I am definitely identifying as a student to the disability justice movement, as well as an optometry student. For a quick image description, I am a light colored skin, femme-presenting Asian person wearing a yellow shirt with ruffles, with a background with a bunch of picture frames behind me and some guitars.
Excellent, thank you, Jenny. And then I will just give Stephanie's description for when they come on. So Stephanie is a disability justice cultural worker, educator, organizer, parent, somatic and ancestral healing practitioner, consultant, writer, and the executive director of Project Let's. Their work specializes in building peer support collectives and community mental health care structures outside of the state. Stephanie comes to their work from the positionality of being white, Latinx, Jewish, MAD, autistic, disabled, and a survivor of psychiatric incarceration and sexual violence. They have extensive experience as a facilitator, curriculum developer, and consultant for mental health policies, program development, and access-centered practices. Stephanie is invested in disrupting multiple carceral systems which disproportionately harm and kill our community members worldwide.
Real quick for some acknowledgements, just to provide some context for the event tonight. As optometrists, we deal extensively with patients who are visually impaired and address treatable and or preventable visual impairments. However, through our training, we receive very little information that centers really the experiences and knowledge of our patients. So this workshop is really seeking to view the profession through the lens of the disability justice movement and introduce historical context and defining principles from that movement and offer suggestions for how we can further shift our profession into the alignment with disability solidarity. We'll be talking about mental illness, neurodivergence, and disability, as we've mentioned, and really centering the narratives of those who identify with those lived experiences. And we hope to challenge optometrists and optometry students to question the ways that we've internalized ableism and sanism, what those words really mean, and the potential of our field and selves to cause or further exacerbate trauma, harm, and violence for disabled and neurodivergent patients. And as healthcare providers, it's super critical for us to understand how medicine has often historically been used as a tool for oppression for multiply marginalized folks. For example, practices of eugenics, forced hospitalization, triage policies, and various practices of pathologization. So we will discuss the movement itself, ableism, intersectionality, and also social and political models of disability. Our upcoming workshop in the series of Building an Inclusive Practice on August 25th will be focused more specifically on situations of crisis response and what solidarity-oriented community care might look like in our various optometric communities and settings. As Dr. Leach mentioned earlier too, about access. Access is a practice and access is a love language. So for tonight's webinar, we have enabled auto captioning, and we will also be vocalizing any image descriptions where it's necessary, but we recognize that this is limited because auto captioning is not always accurate and accessible for deaf audience members. And it also places additional strain on any speakers who don't have a specific white American English accent. And that ASL interpretation, although something we don't have tonight, we're hoping to have at our next event. And it's also incredibly important to have ASL because without it, we exclude an entire language and culture. And so this is a reminder for us that these are often the minimal practices necessary to allow access for folks with disabilities. And access needs are something that we're really hoping that the optometric community will soon begin to consider as the norm, and not only for events, but also clinical and academic settings as well. And if anyone in the audience too has any specific access needs, you can feel free to send a message to myself, Dr. Leach, or Betsy Torres, and let us know. If you need us to talk slower or take a pause, we can definitely do that. Some of the content covered in this lecture can also be sensitive. So if you need to take a break and pause, remove yourself from the webinar, or if anything comes up for you, please feel free to do so. And then just a last note on sitting with discomfort and disrupting power. So during this event, we will be centering the lived experience of mental illness, neurodivergence, and disability, and the perspectives from those most at the margins, most excluded, and those least considered the norm. And this may potentially bring up discomfort, which if it does, we ask you to sit with it, especially if you identify as someone who is abled and recognize moments where you may have been personally harmful or participated in a system that has been harmful in spite of your personal orientation to help. This space is really to challenge what may be commonly accepted as okay, or the norm, and also talk about how systems that are meant to help many of us may have punished, pathologized, criminalized, and even harmed those of us who are in the disabled community, and that both helping and harming can coexist at the same time. And lastly to note is that medicine cannot be removed from its violent, colonial, anti-Black, ableist, sanist, and sexist history. Okay, so medicine and psychiatry both have been used as genocidal tools, and we must contend with this if we are to remain part of this work.
Okay, thank you, Jenny. Here's a brief outline of what we're going to cover tonight. We're just going to spend a little bit of time on clinical and ocular presentations. These conditions, many of you will know, and I know you are all good at finding out more using, the tools we need to find out more about these conditions. By no means is it an exhaustive list. As you will find out from our talk tonight, disability is incredibly intersectional. But these are just some examples of prevalent ocular presentations for you to start thinking about how some of the ways we manage disabled patients can potentially be harmful or ableist as we dive further tonight. And then, as you will likely notice, so many of the ways in which the literature tells us to treat these patients does not fully encompass all that we hope to achieve and should achieve as practitioners. We'll go over some history and definitions, talk about accessible patient care and disability solidarity. And then lastly, we have a pre-recorded question and answer. Jenny did a Q&A with someone about their lived experience, and it's really awesome. So I'm excited for that. All right, so just again, talking just a few brief conditions. Trichotillomania is the pulling of one's own hair or eyelashes secondary to a chronic impulse control disorder. Comorbidities that can manifest include anxiety and disruptive behavior disorders in young people. And then more commonly in adults, they may have anxiety, mood, substance use, eating, and personality disorders. Treatment, as per the literature, includes cognitive and behavioral therapies, supportive counseling, support groups, hypnosis, medications, and any of these combined approaches. Psoriasis palpebrarum is lice living within the eyelashes secondary to the pediculus pubis. It is uncommon in developed countries. However, it may appear in cases of what we would deem as bad hygiene. It may be misdiagnosed as blepharitis. And then importantly, if it's found in the pediatric population, we do need to rule out sexual abuse. So something to keep in mind. Still in the anterior segment, phenothiazine is an antipsychotic medication. If it is used excessively, it may cause pigment deposition on the anterior capsule of the lens and posterior cornea. It has been decreasing in its use over the last 15 years or so because of this ocular sequelae that is irreversible. So if it is present, make sure you talk to your patient's primary care doctor and consider excessive use of the prescribed medication. Oculogyric crisis. So this is sustained dystonic, conjugate, and upward deviation of both eyes secondary to medication use. Can last anywhere from seconds to hours. It may be accompanied by other symptoms such as increased blinking, blepharospasm, increased blood pressure, pupil dilation, and facial flushing, among other things. Patients may also have anxiety and visual or auditory hallucinations. Meds in this category include antipsychotics, antiemetics, antidepressants, antiepileptics, and antimalarials. If this condition is caused by a drug, you will again want to work with the doctor, their primary care doctor, to taper and consider discontinuing. Posterior segment, many of you should be familiar with talc retinopathy. The small crystals found within the retina secondary to an inert drug filler. It's found both within small retinal vessels and different retinal layers. It is a filler used in preparation of certain oral, inhalational, and intravenous drugs. And we are particularly concerned about it because it may cause vascular occlusions within the retina. Nutritional optic neuropathy. is, as we know, painless progressive decrease in visual acuity secondary to improper dietary content. It tends to be bilateral and symmetric. It is accompanied by a color vision defect. It is most commonly caused by deficiency of folic acid and vitamin B complex through anything such as malnutrition, poor dietary habits, incorrectly applied vegetarian diet, or chronic alcohol abuse. It is associated with optic nerve atrophy, which manifests as discolor. We want to treat with dietary supplementation, hopefully prior to any irreversible optic nerve atrophy. And kind of our last little page on, summary of ocular conditions, talking about Charles-Bonnet syndrome. So Charles-Bonnet is visual hallucination secondary to vision loss. The risks are higher if you're patients more than 64 years old, you're socially isolated, lower cognitive functioning, history of stroke, poor lighting, and worse bilateral visual acuity. There was a study that was done in 2020 specifically about the effects of COVID on those patients with Charles-Bonnet. And it showed that half of participants experienced an exacerbation of their hallucinations during the pandemic. Patient reassurance and education play a role in improving their quality of life and really emphasizing social connection. Lastly, Wernicke's encephalopathy and Korsakoff's psychosis. This is also known as Wernicke-Korsakoff syndrome, a neurological disorder secondary to thiamine or vitamin B1 deficiency. Wernicke's encephalopathy is the acute phase, and Korsakoff psychosis is the chronic phase. It's usually caused by chronic alcohol use, but also associated with malnutrition secondary to gastric bypass or gastric or colon cancers. Memory and learning are affected most. In terms of the eye, they may have nystagmus, gaze palsies, ophthalmoplegia, and ptosis, and it can also result in visual hallucinations. So again, that was just a brief summary of some of the conditions you may encounter of, the patients with conditions that we'll talk about tonight. Had to include the eye for this lecture, but definitely excited for the next section, learning a little bit about history and definitions.
Thank you, Dr. Leach. This is Jenny speaking now. So first off, we're going to talk about intersectionality to kick off all of our definitions. We really need to be leading with intersectionality whenever we're talking about any of these topics and social determinants of health, because it allows us the most complex and comprehensive understanding of all the surrounding contextual factors for a person's health conditions. So intersectionality was coined by Kimberly Crenshaw in 1989 and is a Black feminist legal and theoretical framework with origins from as early as the 1890s in different Indigenous communities as well. It describes the interconnected nature of identities, including in the image, it says race, ethnicity, gender identity, indigeneity, sex, class, language, religion, ability, sexuality, mental health, age, education, body size, neurodiversity, housing, income, immigration status, and so much more. And so the ways that people experience discrimination differently depending on how their overlapping identities intersect with various systems of oppression. So since society disproportionately distributes power, privilege, and then discrimination and disadvantage, our approaches to addressing oppression and its impacts on health must not treat any of these identities as independent from each other. So with intersectionality, then we have a much more comprehensive, like I said, way of understanding the social determinants of health. And so you kind of can see from the right image as well, power is centered in the middle, and as it goes out, it's more marginalized. So when we look at ability, those who hold most power are able-bodied, but then as it goes out, there's some disability and then significant disability. And then to the next slide. So this is just another version of Sylvia Duckworth's Wheel of Power and Privilege. I wanted to display it because I want to ensure that we're also differentiating gender and sex. Gender, which is the internally and deeply held identity, man, woman, trans, and non-binary that a person can have, versus sex being oftentimes assigned at birth. And that could be male, female, intersex, and so on, which I'm bringing this up because it was spoken about at the last Building an Inclusive Practice event about transgender care. So when we consider these intersecting aspects of identity, I also want to remind you that these intersections of power and marginalization, it's the complex context for any presenting patient and their respective health conditions. So each person has their own unique experiences with privilege and discrimination. It's not mutually exclusive. People can be privileged in certain ways and discriminated in other ways, all at the same time. Our interactions with these intersections also occur at the micro, meso, and macro levels. This is often a framework that's taught in social work and other things like public health. So micro is really the intrapersonal and interpersonal level, which most of us as providers operate on our day-to-day interactions with patients, or the ways that people may have internalized a lot of these isms that you see here. And then the meso level in the middle is sort of the institutional and community level, which power and marginalization occurs. For example, that could be in a school setting, hospitals, clinics, your neighborhood. And then looking at the broader macro level is the structural and systemic level. For example, the federal, state, city, and municipal, looking at kind of those socio-legal structures too that include policies that may be in place. And for the next slide, I also want to introduce us to this idea of transformative justice. So the baseline understanding is that our society today, we engage in what's called punitive justice. Oftentimes when harm happens, we are meeting that harm with punishment. Someone causes violence, that person is punished. So that is the framework that currently exists, but what we want to kind of shift our thinking towards is more transformative justice, which is a framework for addressing harm within our own communities that create new systems of governance and social relations that reduce harm in the first place. So looking at those root causes, and it relies on processes that try to attempt to transform the social and material conditions that give rise to harm. And then when I talk about harm too, it can kind of extend beyond just physical violence. It includes racism, poverty, inaccessible healthcare, our food systems, and even housing. And then I just want to talk about the DSM-5 because as many of us have learned within our education, this is kind of like the way that we're introduced to mental illness. And the DSM-5 is, as we all know, a compilation of symptoms and presentations of so-called mental disorders that psychiatric professionals reference when they're making diagnoses. But it is important to note, though, that throughout history, the DSM has individualized and pathologized or medicalized many normal behaviors. And also that psychiatric diagnosis is not an exact science, nor are there always precise, accurate, or objective predictors at the best treatment in the same way that like medical diagnoses is. It's more, it's less precise than like taking an X-ray, making a diagnosis through that way, or, you know, taking an OCT and making a diagnosis through different forms of testing that way. So different diagnoses with the DSM-5 can reflect different theoretical orientations of therapists, as well as the biases and social contexts of a given patient and diagnosing professional. So, for example, in history, homosexuality was previously accepted as a diagnosis, but we understand that today as that was homophobia, or diagnoses of hysteria or premenstrual dysphoric disorder, or even hysteria and hypochondriasis are often sexist, misogynist, and further reinforcing of a patriarchal society. So a lot of those terms now, after history, we've now made them outdated and we're no longer using them in the DSM, but it's a reminder that even things currently in the DSM are still problematic. So the DSM tends to pathologize several groups whose civil rights have historically been marginalized and in the dominant culture at large. So if we take a step back and understand that our dominant culture at the baseline is white supremacist and is a cis hetero patriarchy, like that is the norm, the bias is then clear in regard to race, social class, age, physical disability, gender, and sexual orientation within the manual. So symptoms are often in the manual a call for corrected balance. So rather than labeling the symptoms of a sick society, though, when appropriate, the client is often diagnosed in a very individualized way, and it is medicated to adapt to actually an inherently violent and oppressive system. So, for example, we see this where Black men are historically overdiagnosed with psychosis and women are overdiagnosed with bipolar disorder. And this comes in relation to us to, at a previous CE event, Dr. Edward Larry Jones of Pacific University and president-elect of the NOA had presented that 80% of incarcerated youth in a juvenile correctional facility were found to have uncorrected visual problems. So like this intersects with us in optometry because we know from statistics through the past year, especially many people have become heightened aware to it, is that it is usually mentally ill and disabled Black and brown folks who are disproportionately policed at higher rates. So the DSM, it's a powerful tool of social control in a lot of ways, and its criteria is often used to judge who is normal versus who is abnormal, sane versus insane, who should remain free or who should be hospitalized against their will. So it has been manipulated in legal structures before as well. And so, for example, it's been used for like eugenics and sterilization through history of different disabled and mentally ill diagnoses. And also mental health support in general is often inaccessible or prohibitively expensive. And mentally ill people of color are disproportionately involuntarily incarcerated to either psychiatric institutions or they experience violence or are killed by the police during intervention in that way. So with this understanding, we can kind of take a step back and see that like diagnoses, they can be a privilege because they're able to like bring people to different supports that they may need, but it can also be a tool of further oppression. And those two things can coexist at the same time. And then finally, important thing to note as well is that the DSM is very reinforced by the psychopharmacological industry. So each pharmaceutical company has a direct financial interest in focusing on that individualization of pathology rather than looking at like the familial or societal levels of things, because that leads further to medication-based solutions rather than systems of community care. So the DSM is needed in terms of like coding for diseases as well. And then I just want to take a pause real quick because I know Stephanie joined us. Stephanie, if you'd like to just quick say a few words, give an image description, anything you'd like to do.
Sure. Thank you so much, Jenny. And hi, everyone. I apologize for being late, but really excited to be here with y'all tonight. My name is Stephanie Lynn Kaufman Timkulu, and I use they, she pronouns. I'm a white, non-binary person. I have several facial piercings and some long dangly earrings. I have a white shirt on with some blue stripes, and behind me are some beige walls. I know that my bio is red. I just want to uplift that. I'm the director of Project Let's. We work with disabled, mentally ill folks to build alternatives to the mental health system as it currently exists. I am showing up here today as a multiply disabled, chronically sick person. I'm autistic. I have been diagnosed with many things. I have taken a tour of the DSM, as I like to say. And mostly coming, to this space today, I have dealt with a lot of violence as a disabled and mad person in medical systems, in optometry as well. And that kind of theme of being gaslit, not being believed, having your experience in your body mind being discredited because of how you've been labeled is something very real and present for me. So yeah, just wanting to name that is how I'm showing up here today, and really excited to dig into some history and some terminology with y'all. I don't know, Jenny, if you wanted me to jump in here.
Yeah, you're totally welcome to. I also just want to uplift too, is like that a lot of inspiration for our event tonight comes from a lot of the trainings that Project Let's has offered at sliding scale rates. So that's been really helpful for me within our Project Let's chapter at school, being trained as a peer mental health advocate, just learning all these different frameworks as well. Yeah, feel free to jump in.
Awesome. Well, thank you, Jenny. And just from hearing the last bit of discussion around intersectionality and around the DSM, I'm really grateful, Jenny, you're like encouraging us to question what we've taken for granted, right? Here's the DSM, here are these diagnoses. They're factual, right? We give them out, but it's much, much, much more complicated than that. And I think, if all y'all get out of tonight is just maybe asking a couple of, what about the way I think about this? Or how am I thinking about that? I think that's really the goal. And even with some things that we take totally just as for granted as something standard, like the definition of mental health that the World Health Organization gives. So that is on the screen, and it says mental health is a state of well-being in which an individual realizes their own abilities, can cope with the normal stresses of life, can work productively, and is able to make a contribution to their community. In this positive sense, mental health is the foundation for individual well-being and the effective functioning of a community. And when I'm teaching about this definition, I often say it reads like an ad for capitalism, right? It's all about the individual being able to work and produce and contribute something, and very little about actually like how we feel, which I think is a pretty glaring miss, right, from the definition. Also can cope with the normal stresses of life. Like, what does that mean? For a white person in this country and for a Black person in this country, that's going to look different, right? People who are consistently seeing death on repeat on social media, that's ongoing trauma, right? So those are, what does normal stress look like? And I think we see that a lot with definitions and with the kind of foundations of psychiatry as a whole, right? We have had eugenicists, proudly proclaimed eugenicists and white supremacists saying, this is what we are going to consider normal. And when we think about how, DSM-based diagnosis, such as drapetomania, this was a definition that was a category of mental illness that was defined by Samuel Cartwright, who was a pretty well-known eugenicist, and he defined drapetomania as the mental illness that causes enslaved Africans to want to free themselves from slavery, right? So literally pathologizing resistance to significant oppression that was occurring. So really wanting to just take a look at how are we thinking about, how are we defining mental health? And I think, Jenny, if you want to go to the next slide, We have a couple of different ways of thinking about that, right? For us on the right-hand side, we want to think like about the ability to enjoy life. That seems pretty foundational, right, to someone's mental health. Also having some type of skills to navigate life's challenges, thinking about our emotional well-being, our spiritual well-being, and this concept and idea of social connectedness, and respect for culture, equity, social justice, personal dignity. This is why intersectionality is so critical, because when we're talking about mental health, we can't really have an apolitical conversation, right? We have to be thinking about how we struggle with our mental health, right? Even when we look at what's been happening with COVID, it's been really frustrating to hear about just a mental health crisis out of nowhere. It's very important to name that what has happened with COVID is a social, political, and economic crisis that has in turn created a significant mental health crisis, right? Do we really need to pathologize someone who is anxious about going outside during this virus? Do we need to pathologize someone who is depressed because they can't pay their rent or feed their family, right? And when we look at those, heighten some of those contradictions, we can really see some of the gaps in the ways that we talk about mental health. And on the left-hand side of the screen, there is a graphic from Corey Keyes, and his research was around really challenging this notion that everyone who is mentally ill or labeled that way is actively sick or actively not well. So this graphic kind of shows that you can be flourishing and have mental illness, or you can be languishing, or you can be kind of somewhere in the middle. And I think it's really important to recognize that all of what we're talking about operates on a spectrum. We cannot look at one person who's been labeled bipolar and compare that experience and utilize kind of the same expectations and assume that the symptoms are going to look the same. There are some similarities and patterns, but we want to be recognizing that just because you are mentally ill does not mean that that you're not interacting with your community, that you're not engaging in certain ways, that you're not, to use the words that are so often used, that you're not functioning, right? So wanting to push back a bit on that. Awesome. And I don't know if this was mentioned before, but there are a lot of terms that are being kind of thrown around, right? We have on the sides madness, mental illness, disability, neurodivergence. All of these terms have different lineages, different political orientations. But for the sake of this conversation, really important to recognize that mental illness is a disability, legally speaking, which is, if we're thinking about how we're going to orient our practices, right, as optometrists, understanding that legal obligation as well. So we want to be questioning what we think we know about disability. I really would encourage everyone to do like a reflective activity with yourself, journaling, thinking about what do you know about disability before this presentation? Where did you learn it from? Who taught it to you? Because I will tell you that the way that you are educated, not just through school, but through life, conditions us all to believe very, very violent and harmful things about disability. Even myself, as a disabled person, I am unlearning every single day. So there is nobody in this space and in the world that is above continued growth on that front. So we want to be pushing back if we are thinking about disability as something that's solely attention seeking. Or that disability has to be visible. Some people have very visible disabilities. Some people, let's say you have a seizure disorder. That's something that is sometimes an apparent disability, right? If I'm actively having a seizure, other people can see that. But if I'm not actively having a seizure, nobody might know that, I have a seizure disorder. So thinking about that, diabetes, Crohn's disease, epilepsy, all these things are more or less invisible and often get forgotten in the conversation of disability. Also thinking that disability is something fixed and fluid. I'm going to talk about that in a moment. Or that disability is temporary, disabled people are weaker or less than. And, I want to hold space for the fact that as as folks who've gone through medical education, it's very, very hard to unlearn these things because your entire educational praxis and the work that you do is centered on your ability to identify what's wrong with someone, right? Heal it, treat it, fix it, get rid of it, make it better, and kind of move on, right? There's not really a lot of space for holding the complexity of what about if I can't get better? What about if I don't want to get better? What about if I'm being asked to like engage in all of these things in the medical system that, you know, are not even about things that cause me pain or distress. They're just things that other people want to fix in me, right? So really pushing back again against our own internalized ways of like thinking about needing to fix, cure, heal everything. And that if a patient presents with something that we don't know or we don't understand, maybe our gut assumption is they're making it up for attention, or, you know, they are just trying to get drugs from me. They're just trying to do X, Y, Z. That was very much my experience as a 12-year-old who completely lost my ability to see both near and far almost overnight. It was a side effect from Detrol LA, a medication that was treating a kidney infection. And because of how young I was, probably because I had been identified as a woman, I had a history of mental illness. Nobody believed me for several weeks as my vision was just degrading, right? So having that understanding of if I don't see something in a test, if I don't understand what's happening, this person must be lying. This person must be exaggerating. It can't be that they are experiencing something that I can't figure out. So really wanting to just name that dynamic and have folks be questioning that as well. So also just want to give you all the legal definition of disability defined by the Americans with Disabilities Act. Three kind of components to that. The first being a physical or mental impairment that substantially limits one or more major life activity. That is breathing, thinking, walking, standing, all of those things. Having a record of such an impairment or being regarded as having such an impairment. And this is where it gets tricky, right? Because if we're thinking on an intersectional lens, who has access to competent healthcare or healthcare at all? Healthcare that is going to give an accurate diagnosis or believe someone's symptoms. Even for myself, having the privilege of having consistent healthcare, switching doctors a lot and shifting states, if you move, having access to consistent medical records can be really, really tricky. So really there is a strong impulse, especially for disabled folks, of like catching people in the lie and wanting to have a lot of proof and evidence. And that's something that we want to push back against as well. Also wanting to draw the difference between an impairment and a disability. When I'm talking about an impairment, that is a physical or neurological manifestation. If somebody is paralyzed, they have a spinal impairment, right? But what we call disability advocates and organizers are saying, actually, I don't know if my impairment is what disables me. I think what society creates as barriers, that is actually what is disabling me, right? So wanting to kind of differentiate between that. And we can go to the next slide. I'll kind of go into some of the major models of disability, ways we think of disability. The most prominent on the top right-hand side would be the medical model. So that is, as y'all have learned, disability is a health problem that requires treatment and cure. And if this is, 100% just accepted for you, really encourage y'all to dig into some of the resources that come up in this training. There is a lot of writing and resources from disabled folks who really strongly push back against the medicalization of our experiences. In opposition to the medical model is the social model, as I just mentioned, thinking about how disability is something that's constructed. We also have diversity models, thinking about how disability just naturally exists in nature, like disabled people have always been here, we will always be here, and really kind of combining a little bit of the medical model little bit of the social model, acknowledging that impairments can cause pain, they can cause distress. We might want to seek treatment or healing for certain things, but disability, being disabled, that is not something that we want to eradicate. And some of the other models that often come up that are heavily perpetuated in different spaces, the inspiration model. Some of y'all may have heard of the term inspiration porn, when we very much celebrate disabled people for doing very regular things that we wouldn't necessarily celebrate a non-disabled person for doing. Classically, if you see an article, of a non-disabled person, taking a person with Down syndrome to prom, right? And people are like, oh, that's so great. That's so cute. That's so special. The whole concept of special education, what is so special about educating disabled students? Everybody has needs that must be met. We all learn differently. And this kind of the euphemisms around people not wanting to say the word disability. We hear special needs, handy capable, differently abled. And when we use those euphemisms, what we're really saying is that disability is bad, and we want to kind of get around it in other ways, which is why we very much encourage people to say the word disabled or disability. Awesome. Also, just wanting to name that disability is fluid, as I mentioned earlier. On the screen are a couple of photos of Annie Segara, who is a disabled activist, and they have a cane in the first image and a knee brace. And in the middle image, they are sitting in a wheelchair. And Annie writes a lot about the discrimination that they experience as an ambulatory wheelchair user. So a lot of people think if you use a wheelchair, you must be fully paralyzed, cannot walk at all. Actually, many people who use wheelchairs are ambulatory, can walk certain distances, could stand to grab something, but potentially the pain would be too great, or we would have to really, plan ahead. I can walk this much, I can't do this, I can't do that. So really not making that assumption that disability is something fixed. And again, if you see someone one day in your office who's using a wheelchair, the next time they're using a cane, the next time they're using nothing at all, that does not mean that that person is not disabled or is not experiencing pain. We can shift through different moments and different experiences and use different mobility devices at different times. All right. So on the screen, y'all can see kind of two sets of terms. We have identity first, which says autistic people, and person first, which says people with autism. And in the non-disabled communities, we often hear perpetuated that we need to use person first language in order to humanize disabled people. This is actually something that the majority of our community members strongly disagree with and push back against, and actually feel like it's infantilizing to use person first language. And I'll give you an example that with all other categories of identities, we don't use person first language. We don't say person with queerness or person with blackness or person with tallness, right? Because we understand that those are descriptors of a person's identity, and that there's nothing necessarily wrong with that, right? So when we really make that effort, person with autism, person with mental illness, it almost has the reverse effect for our community members. So really wanting to name that, and I'm sure that folks have been taught to use person first language, so wanting to flag that as well. Awesome. This definition of ableism is a working definition that comes from Talila Lewis, Dustin Gibson, and other Black disabled organizers. On a surface level, outside of this definition, when we're talking about ableism, we're thinking about the structural forms of oppression and discrimination that disabled people face. We often don't think about it structurally. We tend to hear about stigma, right? Erasing the stigma, breaking down the stigma. Stigma is something that happens on an interpersonal level. Ableism is thinking about structurally, including interpersonally. So I'll read this definition from TL Talila Lewis. A system that places value on people's bodies and minds based on societally constructed ideas of normality, intelligence, excellence, desirability, and productivity. These constructed ideas are deeply rooted in anti-Blackness, eugenics, misogyny, colonialism, imperialism, and capitalism. This form of systemic oppression leads to people and society determining who is valuable and worthy based on a person's language, appearance, religion, and or their ability to satisfactorily reproduce, excel, and behave. And the last line says, you do not have to be disabled to experience ableism. And just a quick example of that, because people often get confused. If we know, for example, that standardized testing was designed by eugenicists who were trying to prove that white people were intellectually superior to Black, Indigenous people of color, we know that. It is ableist to continue using standardized testing practices for everyone, regardless of if you're disabled or not. Thinking about our culture, our work ethic, this 9-to-5 work day, no breaks, right? That the pace, the working pace that we have as a society, that's also ableist. That impacts everyone, regardless of if you identify as disabled or not. Yeah, and really, again, just wanting to bring this back to where y'all are in your orientation. And again, none of this is coming, with shame. This is for growth and understanding the enormous amount of power and control that y'all have or will have in your respective positions. Understanding that in order to become a doctor, you need to be highly successful, and you have to base part of your identity on your intelligence and what you can produce for others. You're often pushed to your limits, often penalized for needing or seeking mental health care. This is something that we are seeing at astounding levels. I would say almost every week that our organization is being reached out to by medical students in various fields and capacities who are being criminalized or punished for seeking mental health care, are being suspended from their programs for seeking mental health care, are under like surveillance type of programs for seeking mental health care, which is a massive disincentive. And often medical practitioners have extremely high rates of suicide because of the culture of silence and shame, which then gets projected onto your patients. So really thinking about that, that within the same system of education that y'all have had, you get to decide whose life is valuable, who are you going to believe and trust, whose life has meaning, who is worthy of getting treated with dignity and respect. And what all that means is that knowingly or unknowingly, we have all perpetuated ableism, sanism, thinking about the structural form of oppression that impacts psychiatrically disabled or mentally ill folks. So we're all a part of that. And so the use is not to say, well, I care about disabled people and I do this and I do that, really wanting to take an honest and open look at how we're showing up. And thinking about some of the more hidden patterns of violence that happen in our medical spaces and in society as well. Awesome. So just really quickly wanting to show y'all when we're talking structurally, oppression is going to exist on 4 main levels. We have the ideological level. That is, how do we think about these things, right? Do we believe that mentally ill people are dangerous? Do we believe that it's safer if disabled people are in institutions? Do we believe that, disabled people are less valuable? That's how we think about things. On the institutional level, this is how we think about it gets put into policy, gets put into practice. Thinking about mandated reporting, thinking about how we respond to the great majority of folks in psychiatric distress with police officers with guns. As somebody who has been on the receiving end of police officers with guns approaching me during a psychiatric crisis, I can tell you firsthand that that does not calm the situation. It does not de-escalate anything, and it significantly increases the risk of harm, particularly for mentally ill and disabled folks of color. As I mentioned, we have that interpersonal level. That is, what happens between people, what happens between patient and provider. Am I believed? Is my doctor listening to me? Is my doctor infantilizing me? Thinking about those dynamics. And then the internalized level, that is how we take all of the other forms of oppression and we internalize it, we believe it about ourselves, and thinking about how our patients are navigating that as well.
So if you and I.
Hi, everyone. Sorry, Shelby again. Due to time, we do not have, we had a short video inserted here, but due to time, we won't be able to watch it, but we have a handout to send out to everyone afterwards, and we will include the link to this awesome video.
Awesome. Thank you, Shelby. A couple of more notes on intersections with ableism before we move into just a tiny bit of history. Thinking about how disability is overrepresented in every other marginalized community. We really want to take note of the way that health in our society is actually very much positioned in line with what we consider to be associated with whiteness, right? So disability is actually defined against whiteness. Whiteness tends to have connotations of health and strength and stability and intelligence. So when we're thinking about disability, it tends to be in opposition to all of that. We also want to think about the ways that ableism and white supremacy go hand in hand, because we don't want to, walk away with an understanding that, okay, I need to be a better provider to the patients who show up in my office and say, hi, I'm disabled. This is my DSM diagnosis. These are the things that would be helpful for you to do in this environment to make me feel better, safer, etc. We want to be doing these things all the time because many people don't have language to describe how they've been disabled. Many things that are disabling, we don't consider them to be. Are we thinking about environmental racism and the impacts of air quality on Black youth who are being diagnosed with asthma at outstanding rates? Are we thinking about developmental disabilities from lead poisoning in Flint, Michigan? Are we thinking about the impact of long-term surveillance on communities of color, the trauma of incarceration, family separation, right? These are things that cause trauma that disabled people. And it's actually a tool of our society to try and make invisible the ways that disabled people show up in marginalized communities. And we also see this push to give white disabled people sympathy and understanding for their disabilities. But when it comes to Black folks, Indigenous folks, people of color, we often utilize disability or diagnoses as ways to justify dehumanization, to justify continued violence, to say, oh yeah, we knew they couldn't behave, they couldn't do X, Y, and Z, it's because of this diagnosis, right? So very much wanting to start recognizing those patterns around when is it used as an excuse and when is it used as further means to continue harming certain groups of people. All right, y'all. Thanks for bearing with me. I know I am talking a lot and wanting to just get to a couple more slides before we move into our next section. Just wanting to lay out a little bit more clearly the difference between disability services, rights, and justice. So the first being services that are led by non-disabled people. So this might be, thinking more in the medical spaces, right, around different disability services, personal care attendants, physical therapy, occupational therapy, medical providers, et cetera. We have disability rights, which is different as well. This was really led by advocates working to maintain civil rights under the ADA. So focusing on access, focusing on equal rights, and disability justice being led by queer, gender nonconforming, trans, disabled people, and Black, Indigenous people of color who were looking at some of the work of the disability rights movement and saying, wait a minute, we will never get free through the law. The law is one tool for liberation, and we have to actually be saying, wait a minute, there are all these other systems of oppression. We have settler colonialism, we have capitalism, we have white supremacy. How are all of these things connected to each other? And that was really the work and question of the disability rights movement. And Jenny, I'm going to ask you to skip over to slide 33. Awesome. In the interest of time. Cool. So I just wanted to throw on the screen some photos and names of some of influential people from the disability rights movement. On the left-hand side, you'll see an image in a tinted blue of Judy Heumann. And that is her quote on the screen. I'm very tired of being thankful for accessible toilets. Judy was denied a teaching license in New York City solely on the basis of her medical exam because she was using a wheelchair. She was denied her teaching license and she sued the New York City Board of Education. Judy was also instrumental in leading the 504 sit-in. So this was in California. The longest sit-in that occupied a federal building was done by disabled people who would not leave until the 504 portion of the Rehabilitation Act was passed, which was instrumental in securing public funding for disability services, for saying that places who received federal funding had to be accessible and that those costs were not on the disabled person, but were on the institution itself. And again, still, there are a lot of loopholes within all of this, but wanting to name Judy. All the way on the right side of the screen is Ed Roberts. He was considered the first severely disabled person to attend higher education. He was actually denied from Berkeley. So that quote in yellow was from an administrator at Berkeley who said to him, "We tried cripples and they just don't work." So Ed fought and gained admission to Berkeley. However, he could not live on campus because there were no accessible dorms. Ed was a polio survivor and needed an iron lung. So he lived in Cromwell Memorial Hospital because there were no accessible dorms. He had some of his disabled friends come and live with him, and they camped out in this hospital. They called themselves the Rolling Quads, and they were the group that launched the National Independent Living Movement and National Independent Living Centers. So these are community-based spaces for disabled people to be able to live in community rather than institutions. And the Black woman on the screen, Lois Curtis, was also instrumental in that fight. Y'all might know her from the Olmstead decision, the Olmstead Act, which is a federal mandate that says that disabled people must be given the opportunity to live in the least restrictive environment and live in community when able to, when it's accessible. So just wanted to lay out some of the folks from the disability rights movement, and in our follow-up resources, we will link some more information there, and particularly would encourage folks to watch Crip Camp, which is free on YouTube or on Netflix, which is an excellent kind of overview of the disability rights movement. Awesome. Just want to quickly name a little bit of psychiatric survivor history, that there is a very, very rich lineage and history of mad folks, mentally ill folks coming together and fighting psychiatric oppression as well, which really started during deinstitutionalization when folks were being released from psychiatric units, kind of coming together and saying, hey, wait a minute, we experienced egregious human rights violations and really want to start organizing into unions, into groups, fighting for our civil rights and our humanity as well. So some of those formations were the Mad Pride movement, the Mental Patients Liberation movement, and really thinking about some of the critical work that was done to keep folks from leaving psychiatric institutions and then shuffling into prisons, shuffling into homeless shelters, which is a lot of what ended up happening in community. I also want to name a framework that has come in kind of, stark opposition to more medicalized models. And this is the concept of neurodivergence or neurodiversity, which was coined by Judy Singer in the late 1990s. She was an autistic sociologist who really rejected the idea that autistic people were sick and broken. She believed autistic brains simply work differently from other people's, but that they were not abnormal. And autistic advocates quickly picked up this term and have been using it to describe a difference in neurology that is neither positive nor negative. It simply is. And that neurodiversity means that, we have neurotypical people and we have neurodivergent people. And Cassian Asasumasu kind of expanded that concept to really name neurodivergent, referring to anyone who is neurologically different from typical. And really this quote on the screen, she's talking about how it's not a tool of exclusion, that mentally ill folks are neurodivergent. People with multiple sclerosis, neurodivergent. That's a different way that neurology is working, a different wiring. We can become neurodivergent. We can be born neurodivergent, and really a very rich lineage and rich history that I very much encourage folks to take a look into as well. I'm going to ask you, Jenny, if you want to skip to slide 39. In these last couple of minutes. Awesome. Or if you want to go to 40, actually, my apologies. Awesome. Thanks, Jenny. So thinking about accessible patient care and disability solidarity, I just want to name one of my favorite quotes, very simple. Help isn't help if it doesn't help. And I think that as healers, as care workers, as doctors and physicians, we have learned a lot of things in order to support others that our patients, the people we're working with, might not actually believe to be helpful. One of those things being restraints. I'm someone who has been restrained. I have never met a person who has been restrained who has said that that experience made them feel safer and made them feel calmer. So if we're going to restrain someone, like not, having that illusion that we are doing it to help this person, let's name the fact that we are doing it for liability reasons or, because we're scared of what might happen to other people in the office, right? So really just thinking about those dynamics. We don't want to call something help or support if that's not actually the intention behind it. And Jenny, if you could skip to 43. Awesome. I will just name a couple of these, and then Jenny, if you want to jump in, that would be awesome. So just thinking about how has access been denied? Particularly in medical spaces, there are lots and lots of ways that access has been denied. But we want to think about a lack of functioning elevators, accessible bathrooms, parking spots, doctors' offices, and equipment. Many people who use wheelchairs don't get weighed because doctors' offices don't have accessible ways to weigh them. Lots of little nuances there around actually, like, can we get in your office? Like, can we actually even show up to get and receive care. Thinking about this assumption of incompetence that often happens for children, for disabled people, for mentally ill folks, this normalizing of infantilization. This also shows up, and I think that it is on the screen. Yes. Speaking directly to parents or caregivers or interpreters instead of looking at your patients, right? So if you have a deaf patient and you're talking to the interpreter, or you have a disabled patient and you're speaking to their mother, right? We need to have skills to share knowledge in accessible ways that, a child could understand, or a person with an intellectual disability. We don't just pretend like they're not there because, we don't know how to communicate with them. I've already mentioned a couple of these things. I want to particularly uplift being influenced by very stigmatized diagnoses and distrusting people's emotions because of that, particularly with things like borderline personality disorder or multiple personality disorder, which is now termed dissociative identity disorder. There are often very strong associations with those terms, so we want to be pushing back there. As well as understanding how neurodivergent people experience pain and respond to stimuli. There are lots of different trauma-informed practices around showing your patients tools, explaining to them step-by-step what will happen during your examination, right? Things that y'all might take for granted that aren't necessary, but can actually be critical interventions to help de-escalate and prepare disabled people. And the last thing I will say is we really want to abandon this use of functioning labels, high functioning, low functioning. This is something that comes out of literally Nazi Germany to categorize autistic people, whether they were useful for capitalism, whether they could work, or whether they should be killed because they were low functioning. So these terms have really, really terrible roots in eugenics. We want to be thinking around access needs, around support, not around assessing someone's ability to function based on can they work or can they not. So I'm going to pass it back over to Jenny.
Thank you. So we'll just skip the next few slides. The next one is also really similar, but we're going to go right to the pre-recorded lived experience Q&A. So we have a Q&A with Chiara Francesca. Chiara is originally from Italy and is currently residing in Chicago. Chiara is an artist, writer, organizer, acupuncturist, immigrant, and queer former teen parent living with multiple disabilities. They completed a 3-year master in acupuncture at the Pacific College of Health and Science, earned a Master's of Arts in Italian Studies from NYU in 2015, and a Master of Fine Arts in Painting and Drawing from the School of Art Institute of Chicago in 2012, where she was a Soros New American Fellow. Their clinical focus is on mental health, trauma, PTSD, and queer trans health. She is committed to making healthcare accessible and building collaborative healing spaces. Taking a quick pause too, Dr. Leach, I believe there was a question from the audience about what does MAD mean? If Steph, if you could just answer that real quick.
Yes, absolutely. MAD is a term that is in similar ways that queer has been reclaimed, that CRIP has been reclaimed by disabled people. It is a term that has a particular lineage with psychiatric survivors and with people who have been harmed by the system. So saying that I'm not mentally ill, I don't have an illness, I am mad, more often referring to social factors and social conditions that have exacerbated the experience of madness. I would say in the same way that you should not just like walk up to a disabled person and be like, hey, like you're a crip, right? Like, no, like that is a term that has been reclaimed by individual people. So we don't put the label mad on someone. We would wait for someone to say that is how they identify.
Thank you. And then also real quick, the Q&A, Chiara talks about a lot of different like buzzwords as well. And there's going to be the handout with definitions of what those are and resources for you to learn more. Okay, go ahead, Dr. Leach. Thank you, Kiara, for joining us tonight. We're going to have just like a conversation and like hear more about your lived experience and all the things that you have to share based on, your different ways of navigating the world and the spaces that you occupy. My first kind of question for you is just if you could kind of share your lived experience with the eye care profession.
Yes, big question. Thanks for making this happen, first of all. Yeah, and thanks for everybody, being interested in listening. I come to this conversation as a healthcare provider and a community organizer and a cultural worker, but also as somebody who is partially blind and has been partially blind since birth and has had a lifelong experience of being a patient in an optometry setting in different countries, right? So I was born in Italy, was there until I was 20, and I've been in the US for about 15 years. And the healthcare realities of Italy and the US are very different, even though there are commonalities in how patients are treated, right? I think there's so many different layers to that, and I hope that we can kind of uncover those layers as we have this conversation. I will start with talking about the dynamics that are the most common, and they are kind of the things that I encounter every time I go to an eye doctor appointment, which are, in a big sense, many assumptions about what kind of care has been part of my life, being put in a educational role as a patient, and also assumptions about what health and beauty looks like. And I'll break those down a little more. So if that's okay, unless you want to have a follow-up about it.
No, totally. Feel free to, just break that down. And also, like, I think another thing to touch on too is that you've experienced like visiting eye care providers since a very young age, and like that probably looked very different as you had grown up. So also kind of curious your perspectives on how the power dynamics between patient and doctor has shifted as a pediatric patient versus as an adult patient.
Yeah. Yes, and I also would add to that, the gender dynamics of a country like Italy, that is a very socially conservative and patriarchal country in terms of, being a female presenting person going into healthcare settings where the doctors are 99% of the times male, and then being a child, and those things being part of the kind of power equation for sure, versus, the kind of gender reality of the US, which are not perfect, but they're different. So I will talk kind of more from the present moment, and then maybe we can go back in time. And also I will say I was not insured for a very long time in the US. So I was accessing, free or sliding scale care, which was very different than somebody who has the experience of having, quote unquote, good healthcare. And I am now on Medicaid, which is, again, a very different picture of who I can access as a patient versus somebody who has private quality healthcare. Whereas in Italy, healthcare is nationalized and free for the most part. So that's a big difference in terms of access to care. So a typical eye exam for me will look like going into a place that is affordable to me. So that will usually be, Target or a Minute Clinic, or someone who is a generalist and not a specialist in my condition. Just for clarity, my condition, I was born with a cyst in my iris that was congenital, that was removed when I was 10 months old, because the cyst was becoming enlarged and growing towards the optic nerve, which then could have caused issues in a variety of ways. And so I've been completely blind into my left eye since then. And the pressure from the scarring and the pressure from the blood pressure in my left eye being different from my right eye causes, frequent headaches and dizziness and kind of that kind of reality in my daily life. Yeah, so usually I go to the doctor to kind of check on any deterioration in the health of my blind eye, making sure the scarring is not changing, checking on the blood pressure, all that. Yeah, so as I come into the treatment room, one of the things that happens very often is a set of assumptions being made about my needs. Paramount being that I am looking to find some sort of ways for my eyes to look the same, right? So to have quote unquote normal eyes. And also accompanying that assumption is that I have not done any research or I don't know what my options are, right? So oftentimes I encounter kind of a repeated narrative of, have you tried a contact lens? Why aren't you doing a operation or getting a prosthetic eye? People or doctors will refer to my left eye as my bad eye and my right eye as my good eye. They will say things like, it's such a shame for a good looking person to have a blind eye. I mean, I wish it was a joke, but it's not, it happens often. So there's many layers to those assumptions besides like standards of beauty or standards of what's normal that include many assumptions about class, right? And how much it would be to have a prosthetic operation that I have not tried that or have I done any kind of independent research to see what my options are. So that's kind of all part of it. So that's kind of one thing that tends to happen. And the other thing that tends to happen is that oftentimes the doctor has not seen cases like mine. So there'll be many, many questions that are asked that have nothing to do with my health. And there are actually curiosity or being put in the position of educating the provider, right? Yeah, so questions about, just kind of like a medical history that has nothing to do with what's at hand, right? Yeah, so those two things are kind of the very common narrative of what happens when I go in for a visit.
What about the medical profession? What kind of like things allow these kind of like standards to occur?
Yeah, so I think of it as, part of accessibility. I think that there's kind of this discourse on accessibility that is really superficial in the media, that it's like, how wide are the doors and is the bathroom accessible to a person in a wheelchair, right? Which is great. And I hope that every medical building has those things happening. But when I think about, some of the assumptions that I mentioned, that also feels like a barrier to care, right? Because, there's physical barriers, there's financial barriers, right? And those are already there. Including, not being able to pay for a specialist in the US because a specialist is hundreds and hundreds of dollars, and we can kind of have a conversation about financial access too. But having to kind of mentally and emotionally prepare to go into an environment that will be at best unpleasant and at worst just dehumanizing, right, is also a barrier to care, right? Like I have to be in a mental space where I am ready to deal with what happens in the treatment room besides, the actual exam and kind of speaking of my health and all that stuff. So I think about that a lot as a healthcare provider in terms of how do we set up practices that are accessible in a much more expansive way that it's been talked about in the media so far, right? Starting from people's lived experience and understanding what are the commonalities between marginalized patients, and asking ourselves, who are we centering in our practices when we set up a healthcare practice, right? And many times that goes unspoken, right? That the quote unquote perfect patient is actually a middle class, college educated white person, right? Non-immigrant white American person in the US. And we end up centering our whole practices around that ideal patient without understanding that when we set up that ideal patient as the center, we are actually alienating everyone else who does not fit that experience, right? And setting up an accessible practice can be very simple in the sense that asking those questions of ourselves, like, what are the assumptions I'm making about this person that is coming in? Am I treating them as an equal? Am I putting myself in a position of authority? Am I using language that is accessible? Is my decor, right, in the clinic centering certain people, which means that it's leaving other people out, right? So I think just the importance of that pause, of even taking some time to investigate what kind of practices we're setting up and who we are centering in those practices, because it's never neutral, right? Yeah.
Yeah, you like touched on a lot of different aspects of your specific experience, kind of tying in like your experience of, you know, the way that eye care providers can often be perpetuating classism and the assumptions based on classism, and yeah, and frankly like ableism as well. Yeah, so my question for you then is, how does ableism show up in the exam room?
Yeah, right. Ableism is a word that gets more, it's more talked about now than it has been. But, you know, every person that practices medicine will kind of have a different idea of what ableism means. So I can talk about my experience and what that means for me. And we kind of go back to the idea of what is the ideal patient, and that not just being about class or race or education, but also about what health looks like, right? So ableism to me is being a healthcare provider that has a fixed idea of what health looks like, and who measures every patient that comes in against that idea of health, but without any awareness that that's what they're doing, right? So it's judging somebody according to a very specific idea of health, where anything outside of that is labeled as abnormal, right? Or yeah, divergent in some way, and that disability itself is a negative experience in somebody's having, and that our role as a healthcare provider is always to restore them to health, meaning that we're trying to restore them to normalcy, right? Yeah, so I talked about the instances in which a healthcare provider assumed that I needed or wanted a operation that is actually a cosmetic operation to modify what my eyes look like. That operation has no value in terms of health, right? In terms of my health outcomes, in terms of changing my quality of life. From a health perspective, it has no change. It's actually a risky operation to do, right? Those things were not presented to me in that way. They were presented to me as, this is what you need to do because this is what it looks like to be healthy. That is an ableist assumption, right? It's an assumption that stems from the idea that my body is in some way deficient or wrong because I don't look like some preconceived idea of health, right? And the question was never posed to me as to what I needed or what health looked like to me, or that having two eyes that don't look the same is a perfectly fine way to be in the world, right? So this is just one of the ways in which ableism shows up in the treatment room as an eye health patient, right? And then there's millions other ways. But I hope that this example kind of gives you a sense of the tenets of what ableism, how it works in a healthcare setting and what it looks like in real life. Ableism and disability justice have a lot to do with agency and giving agency back to the patient, right? So at least how I was trained in school very much is that I, as the healthcare provider, am the expert, that I know better than the patient, that the patient does not get to determine their needs, but I, as the healthcare provider, determine their needs, right? You can see from this dynamic that the power balance is really off, right? The healthcare provider is the expert, is the authority, and they actually get to call the shots for the needs of the patient. And all of us also have been patients and probably have a sense of how dehumanizing, unpleasant, and frustrating this dynamic is when we are the patient, right? So creating a just healthcare practice also means asking ourselves as a healthcare provider, what does it mean to give agency back to the patients, right? Like, how do we make this dynamic that has so much power imbalance a little more equitable? Not just because it's right, but because I think that it actually has much better health outcomes when somebody comes in and they feel like their full humanity is held in the treatment room instead of, being dehumanized or talked down to, or have their needs not considered. And that looks a little different for adults and for kids, right? And part of that is legal. Like under 18, legally, we don't have as much of a say or choice about what happens to our bodies. Our parents do. And I've had that experience as a pediatric patient in optometry. But I think that, again, we don't have to, think about this as being these super hard dynamic to change. Like the big systemic stuff is hard to change, but in the treatment room, we can actually do a lot, right? For example, as a child, I really wish that my doctor would have asked me if it was okay to put eye drops in my eye, or prepared me for it, right? And describe what was happening. And this really ties into providing trauma-informed care also, right? So what does consent look like in the treatment room, even for kids, right? Telling a kid, I'm going to put these eye drops in your eye because I want to look at the health of your eye. It might sting a little bit, and I'm sorry for that. It's not going to hurt very much. And then describing what you're doing as you're doing it too, right? So very simply saying, you're going to sit here, you're going to look up, I'm going to put 2 drops in your eye, then you're going to sit, right? So no surprises, right? Surprises are very scary to kids, and they're also very scary to folks who have trauma experiences and PTSD, right? Because a trauma experience really, it's just an instance in which somebody's power was taken away from them. So every time we replicate that dynamic of power over, it's another instance in which we play into the trauma dynamic, right? Every time we give power back to the person, it's an instance in which healing can happen, and in which agency can happen, and in which somebody can feel like, I am a full person and I have decision-making abilities, even within, this kind of micro moment of a relationship with my healthcare provider in this room right now, right? And those little interactions can be super duper powerful. And with that, I will also put into that realm of talking about agency and talking about trauma-informed, also the idea of harm reduction, which also ties in with disability justice. Harm reduction simply means that we are allowing the person to make their own decisions about health understanding that people are making the best decisions for them within the context in which they are, right? So what that looks like for me, like just an example from this past week being in clinic, I have a patient who smokes cigarettes and was trying to quit smoking cigarettes. And they relapsed and smoked a couple of cigarettes, and they had a very, very stressful week and kind of like life changes that happened to them. So as the healthcare provider, I could react to that with judgment and shame, or I could react to that understanding that they made a decision that was the best decision for them in that moment to take care of their needs, which were that their anxiety was super high and they felt like they were having a panic attack, right? Yeah, in my experience as a eye care patient, I've had the experience where I went in, for a eye care exam after 3 years of not seeing a doctor because I couldn't afford it, and the reaction from the optometrist was, you really should be checking on your health every 6 months, right? And it's like, yeah, I know that, but I really wish that he did not make the assumption that it was something that I didn't want or didn't know about. And that instead I was trying to do the very best I could given the context of my life, right? Yeah, so that's kind of like harm reduction in a nutshell, and how it can really help in setting up a more equitable relationship between patients and healthcare providers.
Yeah. And when we kind of talk about like who are we centering in the practices, I think something that comes into play is like acknowledging power dynamics, and like trying to best like redistribute power back to those who are most marginalized. And I think another thing that you touch upon too is just the way that like access is so intersectional. Yeah, I actually am really curious to like kind of what brought you into the disability justice space, and like how how do you see yourself moving forward in it?
Yeah, I mean, I think that one of the tricky things about disability justice is that there are such a wide breadth of experience for disabled people that organizing is tricky because somebody who's using a wheelchair and somebody who's blind and somebody who has a mental health condition that affects them on a daily basis, all those people have actually very different needs and realities that they're living through. Whereas other areas of social justice naturally have more commonalities, even though, of course, there is a wide variety of experiences, even within, gender justice or racial justice, right? Like, or class. Yeah, so that's been, I think it's a trickier field than other social justice fields. My experience with it started out as somebody who worked in gender violence prevention and prison abolition work. And then I got very, very burned out doing that work. And as I was involved in social justice movements, I was seeing the people around me also kind of drop off and become really burned out. So the question of sustainability and sustainable social justice movements became much more present and urgent. And that's how I shifted work towards doing healthcare work. And I thought about going to medical school, and that felt daunting in the sense that it felt like going in the belly of the beast in a bunch of different ways. And I was looking at a practice that had a different kind of history. And I came to acupuncture through the history of the Black Panthers and the Young Lords and how it was used as a medicine in social justice circles to support people in recovery from addiction and recovering from PTSD, or support with PTSD and trauma. And also, acupuncture in the US right now is not a medicine that is, it doesn't have the same ties to the insurance and privatized field, right? So it felt like there was a little bit more room to do things like set sliding scale prices and keep it nimble enough where it could be accessible to folks financially, whereas other medicines feel much more entrenched with the medical system, unfortunately, in ways that make them really difficult to practice in a way that exists in some ways outside of that, right? Yeah, so that's how I came to acupuncture and kind of the practice that I do now. And also with disability justice, it feels like in the same way, there's just more room to show up for patients outside of the medical industrial complex, even in terms of, what spaces I could practice acupuncture in. Yeah, and how the history that people have with it versus the history that people have with more traditional forms of medicine, right? Even though, even with acupuncture, people show up with all sorts of histories and fears with needles and with, all their medical experiences enter the room with them, even when they have never experienced acupuncture as a medicine before. Yeah, so that was my hope in practicing that medicine, is that it just offered more flexibility, which so far it does, as I can kind of figure out ways to set up a practice that can be accessible to the most people possible, even though it's a struggle, just like it's a struggle for people who are MDs or optometrists setting up a practice where they can survive and make a dignified living and take care of themselves and not burn out. Like those things are all very, very tricky.
That actually kind of leads us into like the idea of like healthcare for profit and sort of like the roles of capitalism in that. And I'm wondering if you can kind of like expand more on both your personal experiences of that, but also your perspective of that on a systemic level.
Yeah, I think this is probably the part of, conversing with people that I've gotten the most pushback from. Like people usually are pretty down with the idea of making spaces accessible or, not making people extremely uncomfortable, right? Or harming folks. But anybody going into healthcare in the United States, unless they are, have family wealth, it means that they will have an incredible amount of student loans, right? So I think that that's a huge barrier for so many people. And to not move forward right after school from a place of kind of scarcity and fear, feeling like you're already in the hole, so you have to, you have very little freedom in how you set up your practice. And going to acupuncture school also was, over $100,000 that I have in student loans, right? So just again, and I think we also have to get used to talking about money without shrinking and wanting to hide under a table, right? Like if we can tell each other things like, this is the student loans and this is the reality of going to medical school. I think that can be like a baby step into kind of demystifying at least what it looks like to become a healthcare provider and how it affects people after school, So yeah, instead of kind of moving from a place of fear and scarcity, I tried to ask myself slightly different questions, as I came out of school, which were, what do I truly need to live? What does a dignified life look like? And in numbers, what does that mean for my monthly expenses, for my yearly expenses, right? And to try to move away from the idea of I have to make the most possible money as fast as possible because I have these student loans and that kind of like fire under my seat, right? because I knew that if I stayed in that mindset, it just would have led me down a path of practicing medicine in a way that was not aligned at all with my life experience, was not aligned at all with my community. And I will add to that I am a single parent. I have twins that are 20, so they're big babies, but still, right? Like they're going through college right now, and yeah, I think that's something that people always ask. It's like, well, I'm sure that like it's just you. So it's like, no, I have a family, right? And I'm responsible. I'm a single parent. So like I'm saying this because it's like, we can find so many ways to justify ways of practicing medicine that play into capitalist ideas. And also, I want to say that like people's journeys are their own, but I can at least say like, this is how I did it and this is why I did it. And part of why I did it is because I knew that, if I took a job at an acupuncture clinic that only served like upper class, white people, like it would have led me to burnout even faster than doing gender violence work and, prison advocacy work would have, right? And the whole reason why I went to school and wanted to get into healthcare was to center movement workers and people like me, like immigrants, like working class, poor people, disabled folks, like trans and queer people. So I had to kind of train myself to move from kind of this fear and scarcity into like what is possible, and how do I lean on community to survive and take risks that feel really scary, but also if I don't take these risks, then nothing ever changes, and we just set up the same practices for the same people, right? So I don't have all the answers at all. Like I'm struggling to do it for sure, like I have a sliding scale practice. People, I don't ask any questions, like people pay what they can. I have a sliding scale suggestion for acupuncture, and it's $35 to $65, and people pay along that scale however they want. And I also say to people, if that's still too much, you can pay less. We just have to have a conversation about it. And that also means that I cannot pay back my student loans. It means that, I am living like, just paying rent, right? As I figure out ways to do it more sustainably, right? Like it's, yeah, it's like we can do it, and also it's hard. Mm-hmm. And also it's gonna take more and more people doing it so that we can figure out how to do it in a way that is less hard. With the full understanding that the system itself, the financial system itself, it's not set up for us to create accessible and sustainable medical practices for working class people, right? Mm-hmm. Like so it's trying to create something different from how the system works, which it's going to be challenging. Mm-hmm. Yeah, and also I work in a storefront that I and two other people painted over and kind of turned into a clinic, but it's not a slick medical building, yeah, so it's very much kind of like we are figuring it out as we go, and we hope more people join us in figuring out how to create healthcare practices that are different from the ones that are already set up.
One of the things that I think is like the highest risk thing for any healthcare provider is burnout. So I always, I feel like I want to always wrap up on the like, the navigating caring for others with caring for self being a super tricky aspect of being a healthcare provider. Mm-hmm. And that developing tools to care for ourselves is also part of creating just practices, because if we don't do that, then we cannot show up for our patients as our full selves in any way. And again, that's not, I really struggle with that. And that's part of why I also always try to, bring it up and weasel it into conversations. Yeah, because yeah, the burnout is tough. And also, I always also wonder how much of the burnout is the patients and how much of the burnout is existing in unjust systems, and having to work in places that don't recognize our full humanities as healthcare providers either. And that's also part of like wanting to build different practices. It's not just for the patients, it's for the healthcare providers too,
Yeah. Thank you so much for everything that you've shared. For the audience, Kiara has put together this amazing document full of a lot of resources for you all if you want to learn more and see what other people out in the disability justice movement are working on. You can refer to that document in an email that we'll send out after the workshop tonight.
Thank you so much. Good luck, everyone, with your practices. And yeah, thank you for thinking about this stuff.
Thank you. Thank you, Kiara, for joining.
All right. Thank you so much to everyone for joining us tonight. Special thanks to Kiara for that really informative conversation about her lived experience, both as a blind patient and a healthcare provider. Thank you so much to Jenny for doing that Q&A, doing so much tonight, and for all your work in this space. And lastly, thank you to Steph for joining us tonight. All of your wisdom, we've learned a lot, and there's still so much more to come. She'll be joining us again during the August lecture. As we mentioned, we have that handout that we will be providing to you guys. I think it will be a part of Betsy's email, follow-up email, so we'll be on the lookout for that, as well as any questions as well. Feel free to always email us. Our emails are there, and we'll answer some of the questions at the next lecture in August. Betsy, over to you.
I'm here, sorry. Thank you all for a great presentation. This was extremely informative and extremely necessary for our attendees. I'm happy that our attendees were able to get this information because of how important it is. I thank you all for taking the time to provide this well put together lecture. And I hope that you all join us on August 25th for part 3, Disability Justice Framework for Optometry based crisis response for optometrist faculty and students. And then on September 29th, Beyond the Exam, Practical Ways to Improve Patient Access to Care. The recording of this lecture, as well as the one from June, will be emailed as well as available on our website, as well as the handouts. So you're going to get a lot of information, and it's going to be accessible in multiple platforms. Handouts will be sent out within about 2 weeks. Have a great night. Thank you all, and we'll see you soon.